Glad to see you everyone. Today we are going to see a topic related to breast pathology. Let's move on to the topic.
Today we are going to see about the breast carcinoma. It's a quite lengthy topic, so I have divided it into two parts, the part 1 video and the part 2 video. This is the part 1 video where we'll be seeing about the introduction, subtypes, incidence, epidemiology, risk factors and pathogenesis. Before moving into the topic, for a general knowledge, do you know which month is celebrated as the Breast Cancer Awareness Month? If you know, it's very good. If you don't know, let's know about it, no problem. It is the month of October. Let's move on to the introductory part. Breast carcinoma is the most common and deadly malignancy of women. That is, it is a life-threatening malignancy among women. Almost 1.7 million people are diagnosed per year worldwide, and among them, 1 in 3. That is, if 3 people are diagnosed with breast carcinoma, then 1 among them will be dying due to this life-threatening cancer. Not only women are affected, but men are also affected. Men are also affected, but it is very rare. Now coming to the subtypes, breast carcinoma is classified based on the expression of two proteins. These are the estrogen receptor proteins and the HER2 proteins. Estrogen receptor regulates the expression of the progesterone receptor also. Now it is classified based on luminal and the HER2 overexpression subtype and the triple negative subtype. In luminal subtype there will be ER positive and HER2 negative, and HER2 overexpression subtype there will be either maybe ER positivity or ER negativity, and HER2 will be overexpressed, which means it is positive. In triple negative, all the three will be negative, that is ER negative, HER2 negative, and the progesterone receptor is also negative. Moving on to the incidence, breast carcinoma is most commonly seen in women after 30 years of age, which doesn't mean that it is not seen in women less than 30 years of age. It is seen but very rarely seen. And triple negative breast carcinomas and the HER2 types are seen in women who are in their middle age, and high incidence is seen among women undergoing postmenopausal hormonal therapy. These postmenopausal hormonal therapy consist of high amount of estrogen, which causes repeated action of estrogen over the breast tissue, causes their excessive proliferation, which will lead to the malignant transformation. Now seeing about the epidemiology, breast carcinoma is most commonly seen in women of European and the African descent. Through this graph, you can see clearly that the luminal cancer is most common among the three subtypes of breast carcinoma. In this luminal, the European descent luminal cancer is most common, so the peak is higher in this. And next comes the luminal cancer of the non-European descent, like the Asian and the African descents, then the HER2 negative. HER2 negative is least common than the luminal cancers, and the triple negative is leastest common among the three subtypes of breast carcinoma. Now this diagram shows the risk factor for breast carcinoma. The first comes the medications. Previous taking of medications which include the radiation therapy, oral contraceptives, hormonal replacement therapy since long age, and other drugs include the antidepressants, NSAIDs, and other drugs. And living a sedentary lifestyle like the smoking, alcohol, eating too much of non-veg, and eating junk foods. Other factor includes the first menstruation at a very low age itself, like less than 11 age itself, and first pregnancy at later age, like 30 to 35 years of age, and menopause at a later age, and mutation of genes, especially the tumor suppressor gene TP53, and the main gene of the breast carcinoma BRCA1 and 2, and the STK11 gene. Other genes include the SDH1 and the PTEN gene. Exposure, occupational exposure to organic solvents like the benzene, toluene, phenol, etc. And other factor includes the no or reduced breastfeeding, absence of breastfeeding that is, and high density of breast tissue, and positive family history for any other cancer or breast cancer itself. Now coming to the factors that decreases the risk of breast carcinoma, these are the early pregnancy and breastfeeding. In the first two cases, there will be absence of menstrual cycle, where there will be decreased exposure of estrogen to the breast tissue, so there will be decreased proliferation of the breast tissue. In late menarche and early menopause, in late menarche, the female will be attaining menarche, that is starting of menstrual cycle at a late stage only, so there will be decreased exposure of estrogen to the breast tissue, and early menopause, that is stoppage of menstrual cycle at a early stage itself, where there also will be decreased exposure of the estrogen to the breast tissue, so there will be decreased proliferation, reducing the risk of breast cancer, and surgical and medical intervention in family history positive patients. Now coming to the pathogenesis of familial breast cancer, the main reason for this kind of cancer is the germline mutation. And only minority of patients get this kind of familial breast cancer. The main gene mutated here is the BRCA1 gene and the BRCA2 gene. These two are tumor suppressor gene. That is, they prevent the formation of tumors. Failure of its function leads to the tumor formation. The mutation mostly here is the loss of function mutation, where the function of these genes are lost, and the type of mutation here is the autosomal dominant mutation. Now, what are the function of these two genes? That is the BRCA1 gene and the BRCA2 gene. They are involved in the genomic stability. They maintain the genomic stability of the cells. These genes are also involved in the repair mechanism of DNA. You already know that during DNA replication, there will be lot of mismatches of the base pairs, which are corrected by these genes. If unable to correct it, the cell is apoptosized by these genes. When there is mutation, this mechanism fails and will leads to tumor formation and which will turns into a cancer. Now we are going to discuss about the difference between the BRCA1 gene and the BRCA2 gene. BRCA1 gene is located on chromosome 17q21, BRCA2 gene on the 13q12.3. Both of them are involved in producing same type of cancer, that is the breast cancer, ovarian and the prostatic. As I said you before, whatever be the breast cancer, there are three subtypes: the ER positivity, HER2 positivity and the triple negative group. BRCA1 is involved in the triple negative breast cancer group. ER positive group is the BRCA2, and chance of getting ovarian cancer in mutation is high in the BRCA1 gene than the BRCA2 gene. That is, in BRCA1 gene it is 20 to 40% and in BRCA2 it is 10 to 20%. Now some points which are common for these two genes. These two genes account for almost 80 to 90% of familial breast cancer and accounts for 3 to 6% of the total breast cancer, and the cancer produced by these two genes are poorly differentiated, and these two genes are large genes. So hundreds of mutations are distributed along their coding regions. These two genes causes epithelial cancers, that is, the cancers which arises from the epithelium, like the squamous cell carcinoma, ovarian carcinoma, prostate carcinoma. Other genes which causes breast cancer are the P10 genes and the TP53 genes, the guardian of the human genome, and CDH1 gene and the STK11 gene.
Now this diagram shows the detailed description of the familial breast cancer. First is the germline BRCA2 mutation, which will leads to 1q gain and the 16q loss. These are nothing but the chromosomal changes which will leads to the precursor lesions. That is the flat epithelial atypia, atypical ductal hyperplasia, which will leads to DCIS. It is nothing but the ductal carcinoma in situ, which will leads to ER positive cancer. This is luminal cancer. And the TP53 germline mutation, which will leads to HER2 amplification, leading to the HER2 subtype cancer, and germline BRCA1 mutation, which will leads to the same ductal carcinoma in situ, which is a triple negative breast cancer.
Now coming to the pathogenesis of sporadic breast carcinoma, the first subtype would be the luminal subtype, where there will be ER positivity and the HER2 negativity. There will be wide spectrum of proliferation, which means that there will be high degree of proliferation among the three subtypes in luminal subtype, and there will be high expression of estrogen receptor and its associated progesterone receptor. The major risk factor for this type of carcinoma would be the estrogen exposure, and these carcinoma are usually well differentiated and slow growing. Now, what actually estrogen does? Estrogen increases the production of growth factors, for example, platelet-derived growth factors, which regulate the expression of the genes on the epithelial cells of the breast, which causes proliferation of the breast cells during the menstrual cycle. Along with that proliferation, DNA replication takes place simultaneously, normally where there will be mismatch of the base pairs of the DNA, which is repaired during the sleep in the cell cycle. The defective DNA, which is formed normally, is repaired during the sleep in the cell cycle, that is the G0 phase. When there is a disruption in the cycle and failure to repair of the damaged DNA, that causes accumulation of these damaged DNA and causes malignant transformation. Now, the precancerous lesions that are associated with breast cancer are the flat epithelial atypia and the atypical ductal and the lobular hyperplasia. The lesions are due to genomic changes include gain of chromosome 1q, loss of chromosome 16q, and the activating mutations in the PAK3CA. Now, the gain of chromosome 1q and the loss of chromosome 16q is responsible for flat epithelial atypia, and activating mutations in PAK3CA is responsible for atypical ductal and lobular hyperplasia. Now coming to the grades of cancer, the precursor lesions that we seen before, that is the flat epithelial atypia and the atypical ductal lobular hyperplasia, will transform into luminal subgroup A, and the luminal subgroup B. Luminal subgroup A shows slow growth rate and its clinical behavior is indolent or sluggish, which means it does not produce high grades of cancer. But clinical B subgroup, it's not like that. It produces high grades of cancer and the level of proliferation is also high. Now coming to the treatment, the first comes the anti-estrogen therapy. The rate of recurrence of cancer on using this therapy is very low and the cancer responds well for many years. It can even treat metastasized cancer. It is very difficult to treat metastasized cancer through medications, but anti-estrogen therapy can treat metastasized cancer. In some cancers, unfortunately, escape from the anti-estrogen therapy due to their estrogen independent ER function. The next comes the cytotoxic chemotherapy. This chemotherapy provides little benefits, but it is used for the treatment of luminal A subtype cancer. Now coming to the HER2 positive cancers. HER2, this is a receptor tyrosine kinase. There will be overexpression of HER2 takes place in these HER2 positive cancers, which stimulates the signaling pathways, that is the RAS pathway and the PI3K AKT signaling pathways, which promotes cell proliferation and opposes apoptosis. There may either be ER positivity or ER negativity found in the HER2 positive cancers. The mechanism is the gene amplification, which causes HER2 overexpression. There will be high mutation and there will be characteristic intrachromosomal rearrangements also. Now coming to the diagnosis, the detection of overexpression of HER2 gene amplification can be done by immunohistochemistry. We can treat HER2 positive cancers by HER2 targeted therapy. Almost half of the patients receiving this therapy can have complete cure and the prognosis provided by this treatment is good.
Now see this diagram. HER2 gene is located on the long arm of the chromosome 17. Now, when there is HER2 positive cancer, that is HER2 positive breast cancer, the amplification of the long arm containing the HER2 segments takes place. Now at last, triple negative breast cancer, which comprises about only 15% of the breast cancer, that is least common type of breast cancer. They show a basal-like gene expression. This type of gene expression is shown in the basally located myoepithelial cells and they shows presence of TP53 mutation. There will be genomic instability as in ovarian carcinoma. The precursor lesions resembles the serous carcinoma of the fallopian tube. Now coming to the treatment, triple negative breast cancer is actually difficult to treat because the cells are negative for both estrogen receptor and the HER2 protein. So we can use cytotoxic therapy, that is drugs like the doxorubicin, paclitaxel and the cisplatin etc. and agents which are active against the tumors with defective homologous recombination. Now what is homologous recombination? It is actually a repair mechanism of DNA and triple negative breast cancer is a tumor with defective homologous recombination. So we can use agents which are active against tumors with defective homologous recombination. The cancer can recur after 8 years of diagnosis. Now the first part of breast cancer topic is covered. In the next part, we'll see about the morphology and other things. Until then, it's thank you.